I'm not sure. Good morning. Welcome to Grand Rounds. For those of you that are here in person, welcome. For those that are on Zoom, welcome. I just wanted to acknowledge that we're gathered on the traditional, ancestral, and unceded territory of the Coast Salish people. Today's Grand Round, it's a pleasure to introduce my colleague, Dr. Daniel Ennis, clinical assistant professor in the Division of Rheumatology. There are many things to say about Dr. Ennis. He's got and trained specially in vasculitis. He's a rheumatologist. As part of the division, he sees very complex cases and is successful usually in seeing these cases. He's part of a vasculitis network in Canada. He's also has an interest in medical education, and Daniel was our chief medical resident, and was really a treat to be with. He really revolutionized the way morning report was done. And to that end, we actually do, and Danny and I and a couple of others are part of something called St. Paul's Morning Report. But then I learned today, and I think I probably knew, that Dr. Ennis is also part of a podcast that has a rheumatology component, and I think it's called, I'm not sure what it's called. Oh, sorry, Around the Room, RHEUM. So today's topic, eosinophilic granulomatosis with polyangiitis, or as those of us in a different era knew it, Wagner's. Danny?
Thanks, Barry. That was a kind introduction. So I think this is an area of personal interest. I think it's a challenging disease diagnostically, and it has a lot of breadth in terms of kind of the internal medicine workup. So I think it still allows us to flex some of our diagnostic muscles. And so we'll be going through some history and some review of the classification criteria and what that means, and then clinical manifestations, and then finally we'll get to treatment. So nothing relevant to disclose for this talk. So just give a background case for you to think about as we talk through the symptoms and the story here. So 38-year-old woman at age 16 develops rhinitis and recurrent sinusitis, has repeat courses of antibiotics and Pulmicort rinses, and that seems to work reasonably well. But at age 30 develops asthma and has had to visit the ER a couple of times. It seems to have cold and exercise induced symptoms. And she's on inhaled corticosteroids and salbutamol, and at some point has transitioned to a leukotriene receptor antagonist. X-rays show hazy opacities in the lungs, and bronch confirms that this is eosinophilic, greater than 25% EOS. She also has nasal polyps found about a year later. And over the course of this time, she does have a degree of eosinophilia up to 1.2. So the rhetorical question to start, but try and think about what you actually think the diagnosis is. And just because this is a talk on EGPA doesn't mean that the diagnosis has to be EGPA, but more of a case that demonstrates some of the concepts we'll talk about. So keep that in your head. Okay, so here's the outline that we're going to go over. So first, starting with kind of the history of the disease. So historically called Churg-Strauss syndrome, and it was actually initially labeled as atypical periarteritis nodosa. First case was dated back to 1905. It was first defined as a distinct entity by Dr. Strauss and Dr. Churg. That was at Mount Sinai in New York. And they presented their case series of 13 patients. And I think it's a really impressive historical document because they spend a great deal of time and effort outlining the precise clinical characteristics of their patient in this pathology series. So actually worth a read if you literally have nothing else to do. And they published their findings in 1951. And I think what's interesting here is that the eosinophilia ranged quite substantially. So some people had eosinophils of literally 0, and some were up to 29. And these are just some nice photos from the actual publication. So this shows essentially nodular growths within the spleen. And the specific pathology findings showed diffuse inflammatory infiltrates. There were eosinophils, there were granulomas. They also had pulmonary vessel pathology, which obviously we don't get in clinical practice, but this showed similar findings, right? This showed vasculitis, so pulmonary artery showed luminal narrowing, granulomas in the walls of the vessels. There was a vein involvement as well, so not just an arteritis, but also a venulitis. And eosinophilic pneumonia, necrosis, exudate, and giant cells, which is not a specific feature of giant cell arteritis, just a conglomeration of inflammatory cells. Also some nice pictures of skin and renal biopsies. So they did define that there were two important features on histology. So one is angiitis, right? There is vasculitis of some kind, and the other. Oh yeah, I think someone's mic might be on. If you can just check and mute yourself, that would be great. So thanks very much. So angiitis, so this can be granulomatous, but it doesn't have to be. It does involve arteries and veins, as well as pulmonary blood vessels, as you saw. And there's typically extravascular necrotizing granulomas. And typically you see an eosinophilic infiltrate, and there's a couple of reasons why you might not see it. These days it would typically because patients are often on treatment, and eosinophils are extremely sensitive to steroids, so they literally disappear within days of initiating treatment. Cutaneous lesions importantly lack diagnostic specificity, so don't get too excited if you do a biopsy and it shows that there's some eosinophils in it. Like, that's not a big deal. A lot of different vasculopathies do have some degree of eosinophilia, so not going to be diagnostic, but consistent with. So the classification and criteria are important, probably more as framework. These are not diagnostic criteria, and that is actually really important. So these were the initial criteria. You needed all three. And I think this would be a pretty easy call, right? They have asthma, they have high eosinophils, and they have vasculitis in 2 or more extrapulmonary organs. Yeah, I mean, I can't really think of a lot of other diseases that do that. So that's going to have a pretty high specificity and a pretty and reasonable sensitivity at the time. So those are early criteria. And just pay attention to the eosinophils greater than 1.5. Oh, it looks like we have a question. Yeah.
I was wondering if the age of onset of asthma was important, like if it was childhood versus late adolescence or adulthood.
Yeah, so the question was about timing of onset of asthma, and does age kind of differentiate disease? Sort of. So childhood onset asthma is not directly associated with EGPA, but worsening of childhood onset asthma would be essentially the same as developing new asthma as an adult. So that would be kind of a clue that there's some new additional syndrome going on. But it actually wasn't labeled in if we're talking about these criteria, there was no age cutoff. It's a great question. Okay, so then the 1990 ACR criteria, which actually Anthony Fauci was part of creating. So he was actually all over the early rheumatology literature. He was part of designing some of the early cyclophosphamide trials and regimens. So he's actually pretty prominent in our literature. And so busy slide here, but the things bolded and underlined are kind of the main concepts. So you need 4 out of 6, and the sensitivity is pretty good, and the specificity is excellent. So you need 4 of asthma, eosinophilia, mononeuritis or polyneuropathy, non-fixed pulmonary infiltrates, paranasal sinus disease, or extravascular eosinophils. So that is, that looks like a really impressive specificity, but I think when we are looking at trying to diagnose people with these diseases, or when we're trying to rule it out, right? You have someone, they have some asthma and eosinophilia, and you're like, I really don't think that they have the disease. I would like to exclude EGPA. This isn't actually that helpful. The entry criteria to use these criteria is that you already think they have vasculitis, right? So all of these vasculitis criteria are differentiating different types of vasculitis. This is not diagnostic criteria. So just keep that in mind, that you've already needed to confirm that they have vasculitis. Okay. We're actually going to skip this. Isn't that this is kind of saying what I just said. But here are kind of the major issues that you need to kind of consider along with these criteria. They're derived from 20 cases of EGPA compared to just under 800 other vasculopathies. The criteria don't help us differentiate EGPA from other eosinophilic disorders, which is actually the diagnostic conundrum that we have. And it's possible, to essentially meet the criteria without having first confirmed that they have vasculitis, unless you know that background, that you shouldn't do that. You need them to have vasculitis first. Okay. And then we get to the Chapel Hill definition, which is actually quite helpful. So historically, EGPA was actually categorized along with PAN, and they actually do have a fair bit of overlap in terms of the histology, especially in very advanced disease. But that made it really hard to do clinical trials that involved EGPA with the other ANCA vasculitides, that essentially made it its own distinct disorder and was often studied with PAN, but they're really distinct entities. And this definition kind of helped articulate that it really should be separated out. And then finally, we get to the newer draft criteria from 2018. So you need 5 or more. And the sensitivity and specificity look a lot like the ACR criteria. And it has pretty similar items in there. So I don't think there's a lot that's distinct, but it's essentially the same problem as before, which is you must have vasculitis first. Just to note, though, at the bottom there, having a C-ANCA or PR3 antibody or having microscopic hematuria argue against EGPA. The concept being that if you're ANCA positive, which we'll talk about, it's almost always an MPO, 90% of the time. And the majority of people with MPA don't have significant renal, with EGPA, don't have significant renal involvement. It is a slightly rarer manifestation. Okay, so let's talk about clinical manifestations and therefore some of the mimics that we might bump into. So starting with the 3 phases here. So phase 1 of EGPA is a prodrome, followed by an eosinophilic phase, followed by a vasculitic or systemic phase. Phase 1. So this is where you start with asthma. And this is why it can be really hard. You actually shouldn't diagnose this early on in the disease. That would be a massive overcall. Tons of people have asthma, fewer, but still lots of people have eosinophilic asthma. And a tiny fraction of those people are going to have eosinophilic asthma. That's because they have an underlying vasculitis. So phase 1, you really can't make the diagnosis. Asthma is very, very common. It really should be there in pretty much every single person you diagnose with EGPA. And if they don't have asthma, it's a pretty good rule out test. There are going to be a couple exceptions, of course. Sinusitis and polyposis is quite important too. And rhinitis is in there too, but not the most common symptom. And then you move on to phase 2. So this is the eosinophilic phase. So you have that asthma in the background, and now you're starting to get eosinophilia that may rise to the point that you actually start to get deposition. It's seen in around 90% of patients, which means that there are some patients who are not going to have a significant peripheral eosinophilia. And the mean at diagnosis is about 7.5. So if you saw someone with EOs of 7.5, you'd be pretty concerned. That's really high, and that's the mean. The range on it is quite broad, though. From normal to like 30 to 34. The higher you get, the more likely you are to get significant organ infiltration. And that is not distinguishable from other eosinophilic disorders of any other cause. Any disorder that has high eosinophilia can have eosinophilic infiltration. But you start to see the pulmonary infiltrates, you start to see cardiomyopathy, GI involvement, other manifestations as well in there. And then we get to phase 3, which is now you really should start to be suspicious of the diagnosis. This is when they develop overt vasculitis. Skin is common. Peripheral nerve is relatively common. Renal is rarer. If you look at a nephrology case series, it's like 85%, but that's a nephrology case series. If you look at other case series, it ranges quite a bit. CNS involvement is seen. Cardiac involvement is probably underdiagnosed. And GI involvement is probably also a little bit underdiagnosed because it's kind of hard to, it's cumbersome to make the diagnosis there. So those are our three phases. And that's pretty consistent in the EGPA literature that it tends to follow this pattern. The range from onset to from prodrome to vasculitic symptoms, the range is set at 0 to 61 years. I think the people who are 61 years, these are probably people who had childhood onset asthma, and then their asthma got worse. So when do you actually time the prodrome to vasculitic phase? A little hard to say. But I think the median is really much more important to think about. And I'd say the number that I keep in my head is about 8 years from onset of asthma to the remainder of the systemic phase. So let's talk about differential and workup. So, this is a bit of a heavy slide here, but I think these are kind of important entities to be aware of, especially, so EGPA, that's what we're talking about today. HES is hypereosinophilic syndrome, and these can be clonal or reactive proliferation of eosinophils. Importantly, asthma is rare. These people really don't have asthma. That's not really the basis of the disease, but that's different than lung involvement. Lung involvement is actually not uncommon, but it's more infiltrative lung disease. They have organomegaly. They have no specific preponderance to have polyposis or chronic sinusitis. So it's really a infiltrative disease. And essentially, a hematologist probably won't see the patient unless they have EOs consistently over 1.5. And then we have allergic bronchopulmonary aspergillosis, right? So this comes with asthma. The minority of patients may have rhinosinusitis, cough, brown mucus plug. So, classic clinical picture that goes with that. Some classic imaging that you might find. So bronchiectasis, mucus impaction, and then positive serologies for the disease. CEP, which is chronic eosinophilic pneumonia. So eosinophilic infiltrates into pulmonary tissue. This actually does often have a history of asthma. They may have a history of atopy as well. So they could have polyposis, but that's not a standard feature. So primarily what you're looking at is asthma with some eosinophilic pneumonia features. And they do have kind of convincing imaging findings that may go with that. And it's really confirmed once you have a bronch that confirms that they have an alveolar eosinophilia. The last one on the list is aspirin-exacerbated respiratory disease. And I think unless you're in respirology or allergy, this is probably not something that you've bumped into too often, or I've not, or I didn't know when I saw it. But it can have asthma, it can have rhinosinusitis, it can have nasal polyposis. So that starts to look, of all of these, starts to look maybe the most similar clinically outside of the high eosinophilic burden in HES that gives you all those infiltrative diseases. AERD may or may not have significant eosinophilia. And the imaging is non-specific. And so it just needs to be something that you kind of like keep in your head and have in the back of your head. I have started to ask people if they have reactions to NSAIDs or aspirin specifically. Okay. So this workup, I don't know if it shows up on your screen. Yeah, I think it misses at the bottom, but the things that are highlighted in red are based on a task force, in 2015 task force that decided what should be the baseline workup for EGPA. It's a European document, and so that's why they look for Toxocara. I don't know if you've ever seen Toxocara, but it's pretty rare in Canada, or at least we don't look for it. So that one, not so much. But there's a lot of other stuff to think about, right? So you may wonder, depending on clinical picture, do they have schisto or histo or coccidioidomycosis? We often add to this Hep B, C, HIV in preparation for suspected immune suppression. But that's not really part of eosinophilic workup. So I think there's a ton to do here. And actually, there's a really nice paper, sorry that you can't see the at the very bottom there, but Dr. Dagon and Julia Tin, who are in our department, and Dr. Carruthers, as well as Luke Chen, put together a really nice paper that kind of goes through workup of hypereosinophilia. And it's European Journal of Hematology 2020, if you can't see that. Absolutely worth a read. I thought it was really, really nice. So let's talk about ANCA in EGPA. So it's positive. I usually quote 40% or 50%. It's essentially a flip of a coin, whether it's going to be positive or negative, which means it is perfectly useless in terms of like negative predictive value. So that doesn't really help us. In people who have more vasculitic manifestations of disease, they are more likely to be ANCA positive. If you are ANCA positive, it's almost always going to be MPO. And you should be pretty suspicious if it's a PR3. You should wonder if you're actually just looking at GPA. And that does have clinical implications. And then if you try and divide manifestations by ANCA status, the ANCA positive, as I mentioned, more of a vasculitic phenotype, whereas ANCA negative, more of an infiltrative phenotype. And I do wonder if to a degree that is more based on the fact that you're more likely to make the diagnosis earlier on if they are strongly MPO positive. There's, that pulls things together really quickly for you diagnostically. Whereas if they're ANCA negative, they may float around for a little while before they actually get a diagnosis. I don't really know. So we can talk about treatment, and I'd suggest going to, this is kind of the guideline that was put together, published in 2021, but it's a 2020 update. Broadly speaking, we divide into induction therapy and then maintenance therapy. And these are distinct. They're distinct pathophysiologically. They respond differently to medications. And so it's important to know where in someone's course you are before you pick a treatment. And EGPA is distinct from GPA and MPA. Importantly, EGPA is often excluded from other ANCA vasculitis trials, historically because it was paired with PAN, but then now because it seems to just be a different disease with a lot of overlap. So I think that's important. So everything that applies to GPA, MPA does not apply to EGPA. The first decision is, does my patient have severe disease? Or does my patient have any life or organ threatening disease? And you can be helped in making that assessment by what's called the 5-factor score, which we will talk about right now, I guess. So the 5-factor score, there's kind of two forms of it. There's the original one and a revised one. Primarily, you want to use the original one to make treatment decisions. So on the left side of this chart, you can see renal insufficiency, proteinuria, gastrointestinal involvement, cardiac, and neurologic involvement. And when they say neurologic involvement, what they mean is CNS involvement. All of these are prognostic indicators for mortality. And every point that you add increases their mortality quite substantially. So I think even 1 point reduces your mortality or increases your mortality by about 15% or so, maybe up to 20. And just to put those numbers in context, so 1.58 for renal insufficiency, that's about 140 in terms of creatinine. Okay. And just to explain, the revised 5-factor was to kind of broaden the types of vasculitis for which you could prognosticate mortality. But we don't use it as much to make treatment decisions. It contains a lot of the same stuff, but just because someone's over age 65 doesn't mean you give them more aggressive treatment. It's just that they have a higher mortality. Okay. And just as a memory aid, I find it helpful to I wrote it out there. So GRACE, GI, renal, age, cardiac, ENT manifestations. These are kind of components of the revised 5-factor. All right. So here's just an overview of induction therapy. So on the left, you decide on severity, severe or not severe. And part of that can be your own internal interpretation. If someone has terrible neuropathy, sure, they don't have an increased mortality risk based on our 5-factor score. It's a peripheral neuropathy. It's not central nervous system disease, but they're really, really debilitated. or it's really progressive or something, in that case, you may decide that this does actually warrant more aggressive therapy up front. Or if they have an organ for which they are very likely to lose function, like the eye. So the eye involvement in ANCA vasculitis is notoriously bad. People can lose vision quite quickly. And so those are also people who you essentially may say, it's organ threatening because the eye is involved. We're going to more aggressive therapy. So all of the regimens require glucocorticoids. There is no glucocorticoid-free arm. And you may be aware of the PEXI-VAS trial, which did not include EGPA. So that's for GPA, MPA. And glucocorticoid should be tapered not at that fast pace that we learned in the PEXI-VAS trial. Or if you do, you're making it up. So you might choose to do that, but that's not been studied. And then if they're severe, you think about additional immune suppression. And typically speaking, if someone's severe, you would probably be making the right choice to give that person cyclophosphamide. And there's different regimens for that. Don't worry about that. But we're also going to talk about rituximab. Rituximab is clearly indicated in GPA and MPA and has a lot less rigorous study in EGPA specifically. Historically was not felt to be that powerful. Anecdotally, at various vasculitis clinics, people have not felt that it was all that helpful as a steroid-sparing agent, but we're going to talk about why that might be. For non-severe disease, the literature there is actually really confusing. So we don't find, for non-severe disease, prednisone alone appears to be as good as prednisone plus Imuran. Imuran and cyclophosphamide are about equal in non-severe disease. So even that was studied. So kind of, A plus B equals C, like you can kind of logic out prednisone monotherapy seems to be about as good in non-severe disease as AZA or cyclophosphamide. That's a bit unusual. But in relapsing disease, people tend to do better if you add a DMARD in, like give them azathioprine or Imuran. So it seems to be in the relapsers that they benefit most from being on a second agent in addition to the prednisone. It seems like in first presentation, new diagnosis, non-severe disease, prednisone alone is absolutely defensible. I find that very odd, and I'm not sure how to interpret that. And the trials were a little bit sloppy. So I don't know if that's like the most convincing evidence. Okay. So just to give, brief recommendations from the CANVAS documents. So initial dose of prednisone, about 1 milligram per kilogram per day. Don't go over 80. There's no good evidence for that particular recommendation. That's more pattern of practice. You can use pulse methylprednisone in cases of severe or organ-threatening disease, but it's not been studied. And you should taper according to essentially use a protocol that's been used before. So you try and start tapering at about 2 to 4 weeks. For cyclophosphamide, that's essentially, we suggest the combination of glucocorticoid and cyclophosphamide in patients with severe newly diagnosed EGPA. Patients with non-severe, without any major organ involvement or poor prognostic indicators, glucocorticoid alone is fine. Okay, we're actually going to skip over these studies because they're a pain in the butt to talk about. So sorry about that. Yeah, let's talk about maintenance therapy for a minute. We'll come back to biologics in a second. So EGPA vasculitis of all severity, there's a high fraction of people who are going to need prednisone long-term. And in the largest cohort, which is the French vasculitis cohort, so over 300 patients with EGPA, the average dose of prednisone that patients in that cohort had to stay on was somewhere between around 12 milligrams. That's quite a lot. I would not be satisfied if a patient was stuck on 12 milligrams chronically with no ability to get them off that. But anyways, that's actually fairly common to see, and we'll talk about why in a minute. In terms of other immune suppressants, so there's low-grade evidence for pretty much all of these except for AZA. AZA is the best studied of all of these and seems to work reasonably well as a maintenance agent. Duration of treatment, we really don't know. And we typically borrow from the other ANCA vasculitis literature to decide how long to treat people for. Big picture, somewhere around 2 to 4 years as an absolute minimum of treatment. Treating someone for 1 year, probably a waste of time. They will probably relapse. Let's skip PCP prophylaxis so that we can get to the fun stuff. So biologics and EGPA, I think, is really worth further discussion. Oh, I think someone listening has their mic on again. If you're able to turn that off, that would be great. Okay, so rituximab for induction. So as I said, most major trials exclude exclude EGPA, and therefore we don't really have a ton of great trial data, but some is in process. So one's called the REOVAS trial. So this is Ritux for severe or non-severe disease compared to cyclophosphamide/prednisone, which is considered conventional therapy in EGPA. There's also the main RITSIG trial, rituximab versus AZA. That's also for remission, I should say. We'll get to those in a minute. So there are a couple of preceding retrospective case series, and there might be a prospective case series. I'm going to give you the big picture takeaways from these. So in this retrospective case series, rituximab seemed to be successful. So about 80% of people improved on rituximab. And this is a lot of like refractory relapsing patients. So 80% improved, up to 50% achieved remission, and ANCA positive patients seem to respond more favorably. That's the takeaway. This is another retrospective study, but they at least compared rituximab to cyclophosphamide and largely felt that things looked very similar between the two, but small numbers, retrospective. Here's another retrospective study, a little bit bigger, so 69 patients, and they were all treated with rituximab, and largely the majority of patients had some kind of response or partial response. So these are signals of benefit. These do not prove that it's good or even as good as other therapies. And then there were actually some data that show that ANCA positive patients seem to respond quicker and have longer relapse-free survival than ANCA negative patients treated with rituximab. So I think that that's kind of interesting and kind of flavors whether you're going to choose to treat this person with Ritux or cyclo, if Ritux is even appropriate or on the table. Not the most flattering picture of this guy, but this is Benjamin Terrier, who's a major vasculitis researcher in France. And the REOVAS trial, so part of the data was presented just recently at a conference that we attended. I think this is worth going over. So they took patients who had EGPA. They had to have what's called a BVAS or vasculitis activity scale score over 3. So these are people with truly active vasculitis. They did a multi-center randomized controlled double-blind and superiority trial that tried to assess rituximab regimens versus conventional strategies. And what does kind of conventional strategies mean here? So just to tease that apart a little bit, so you can see at the bottom, so experimental therapeutic strategy is the rituximab. And they gave doses very similar to what we do in other ANCA vasculitis. So a dose at day 1 and a dose 2 weeks later. And that's the induction. And that should last you for 6 months most of the time. Compared to conventional strategy. So in the conventional strategy arm, they divided into 5-factor score of 0, right? These are people who do not have prognostic indicators of mortality or high mortality, and people with a 5-factor score that's 1 or more, people who do have a risk of an increased risk of mortality. So if you had a 5-factor score of 0, you just got glucocorticoids. And if you had a 5-factor score greater than 0, you got cyclophosphamide induction. So those kind of 2 arms there compared to rituximab. To kind of give you the major takeaways from the trial at the 6-month mark, 5-factor score of 0, there was no major difference that was detected between rituximab and glucocorticoid monotherapy. Not a huge surprise. Most people achieve remission if they are 5-factor score 0, non-severe disease. You can get them to remission with prednisone alone. No surprise there. What we really care about is people who are 5-factor score greater than 0, people who you actually might want to put on more potent immune suppression. And that's really where you're comparing the rituximab versus the cyclophosphamide. That's the real head-to-head battle we care about. And it appeared similar. We need a lot more digging into this data before we can kind of recommend that more fulsomely. American recommendations for EGPA have actually already endorsed the use of rituximab. I think that's a massive overcall, and I don't think that anyone should listen to that. I think you need to know this data if you are even going to think about using rituximab off-label for a disease in which it's hardly studied at all. So I don't know exactly how they got to that conclusion, but I fundamentally disagree. So I agree with this, though. This is the Canvas recommendation. Consideration of other off-label therapies for EGPA should be made in collaboration with centers of expertise, and that includes rituximab. I think that makes sense. So it's not that there's no data for it, it's that it shouldn't be the go-to agent for all ANCA vasculitis of all severity in all cases. It really needs to be stratified. Mepolizumab is an important agent as well. And so this is the MIRA trial. So Wexler published in New England Journal in 2017. And it compared mepolizumab 300 milligrams injected under the skin subcutaneous monthly versus placebo. These were patients with refractory, relapsing, or glucocorticoid dependent EGPA. They did not include new diagnosis or severe disease. Right? So these are relapsers, essentially, more challenging to treat people, non-severe. So remission at week 36 and 48, you can see 32% versus 3%. Relapse rate, 56% versus 82%. And I would say the most important item, you can see the curves on the side there, right? They really seem to split apart. So that's kind of an impressive looking graph. But I think a really important takeaway from the trial is that they really didn't dive into, for what did mepolizumab work well, right? I don't think that it's reasonable to assume that all medications are going to work for all manifestations in a disease that is by its very nature multi-organ, multi-system, and immunologic, right? We don't really have even good conceptions of the pathophysiology of these diseases. So it kind of pools all that together and kind of gives the impression, well, it seems to work. And that is useful. But what I really want to know is, well, if my patient, the big problem is skin vasculitis or renal vasculitis or ENT problems or asthma, which one do I use it for? You can kind of, and even their supplementary data doesn't really talk about that. But I think what's important is these upcoming studies. So this is, the reference is here. Oh, you guys can't see it, sorry. So this is Canzian, October 2020. So this is publishing on the French experience with biologics in EGPA. This is really, really important. I'm going to skip back to the mepolizumab data for a sec, just because we were talking about that. But I think this is a pretty helpful overview of the value of mepolizumab. So this is like registry data, so it's not prospective. But what they really help us with is the main problem in Canada, which is mepolizumab 300 milligrams is simply not available. So it's great that we have a trial that says, broadly speaking, it seems to work for this disease, which manifestation, not sure. But 300 milligrams looks almost entirely the same as 100 milligrams. And that's really helpful because 100 milligrams is accessible for eosinophilic asthma. Mepolizumab was not invented for EGPA. It was tried in atopic dermatitis. It was tried in eosinophilic asthma and a couple other allergic diseases before we got to EGPA. And it works really well in those diseases. You can certainly infer that at least part of the benefit in the MIRA trial was that it works on the eosinophilic asthma, because we know it does that. So that is probably a major contributor to those improved numbers and the lower reliance on steroids. Most of the residual symptoms in EGPA are really the sinonasal disease and the asthma. both things that had been actually trial tested with mepolizumab before EGPA. So the thought is that it may really have no benefit for the vasculitic components of the disease. It really works on sinonasal, ENT, RESP. We don't know that. So we actually probably can get 100 milligrams, which is great. And the CANVASc recommendations say 300 milligrams monthly can be considered a non-severe, glucocorticoid-dependent, refractory, or relapsing EGPA. This was published before we had any data that really told us that probably 100 milligrams is a reasonable substitute. And I still wouldn't say that that's, guideline level evidence. That would be expert opinion. And this is just to kind of put it on the spectrum to compare it to other biologics. So we have mepolizumab and omalizumab. Omalizumab is kind of a bit of a waste of time in this disease unless they have like lots of, maybe it could work for the asthma, maybe for the sinonasal disease. There is no basis to think that it would work at all for the vasculitic components, so we don't use it. But look at the top. So the rituximab up there does not look so hot, right? By comparison, even to mepolizumab. So we really do need to think about rituximab and where it fits in the spectrum of disease. So in summary, there is evolving evidence for rituximab. It does seem to work in some people, but it doesn't replace cyclophosphamide in our most severe cases. To add to this, it may be better in patients who are ANCA positive, but that theory has not been tested in large clinical trial. Mepolizumab does show consistent benefit at treating people without severe life-threatening disease, but we're not entirely sure which manifestations it works for. It does probably work for the asthma and the sinonasal disease. And omalizumab don't like nasal polyps and the asthma, perhaps it offers a bit of benefit. So talking about then what's coming down the road, this is just kind of a big diagram of all the different targets and all the different agents that are under study. So there's like 15 on this slide, tons of different targets in EGPA, but we're not sure which one is going to treat all the symptoms or part of it. So if we return to our case for a minute, so 38-year-old woman, rhinitis, sinusitis, later develops asthma. She has some ground glass opacities in the lung. She has nasal polyps, and she has mild elevated eosinophilia. So at the beginning, I said, oh, what's the diagnosis? And like, oh, well, it's EGPA. I would say that although that's probably the answer, I would say this patient actually does not have any demonstrable vasculitis. And so this person I would label, after I have considered all those mimics that we talked about, perhaps involve hematology, perhaps involve allergy if I need the help to investigate those diseases, I would label this as probable EGPA. And just to make sure that I do not kind of close the door on the possibility that I am missing something else, because some of these symptoms are so common. Rhinitis, sinusitis, asthma. Are these frequently screened for EGPA in a rhinologist clinic? No, not a chance, and they shouldn't, because they're very common disorders. So just something to think about. So I guess I will leave it there, and I'm happy to answer any questions. Not sure how to solicit questions from people online, but you can try and ask.
They should be able to ask. Yeah.
Oh, okay. Well, you can ask.
I have a question.
Oh, we got a question here. Sure, Alex.
As a non-rheumatologist, I'm curious what your perspective would be on if rituximab, cyclophosphamide, and pulse steroid for long taper at low dose for a long time had exactly the same efficacy or effectiveness outcomes.
Yeah.
Which drug would you choose to be on?
Rituximab.
Yeah.
I mean, all of them kind of need to be paired with prednisone typically. So, if you're saying, I should repeat the question. If it turned out that pulse steroids, rituximab, and cyclophosphamide all had exactly the same efficacy in the disease, they all work just as well, which one would I prefer to be on? And the answer would be rituximab. Cyclophosphamide is a really effective agent, but because I'm young-ish, there's a long-term risk of urothelial cancers very, very low at the doses that we use it at now. Previously, people would be on oral cyclophosphamide, which is about double the dose, for 2 years. And now we give IV cyclophosphamide for 6 months or 3 months. So like it's almost not comparable, but there is a risk of urothelial cancers, and I'd prefer to avoid that if I could. Rituximab does not have such a malignancy association, but hypogammaglobulinemia, major infections, these are real problems, and we need to be kind of aware of those things too. But yeah, and steroids are the worst. They're terrible, right? They're necessary, but we're all on the same side that we want to be on as little as possible. Yeah.
Oh, thanks for that presentation, Danny.
You got it.
I guess, in your experience, how many people are coming over from respiratory referrals for difficult to control asthma, query EGPA? And then related to your mepolizumab data, how do you think that changes your diagnostic ability or the clinical behavior if their run-in has been with biologic, either IL-5 block or anti-IgE antibodies?
Yeah, so questions about, first question is how many people are really coming through like asthma clinic or difficult to control asthma. I'd say half would be through hematology for eosinophilic disorders and they have asthma, and then half would be through respirology because of difficult to control asthma, but they always have like something else in there too. And then in terms of kind of how exposure to mepolizumab, if they're coming through respirology, kind of changes the way, affects our diagnostics. I haven't, to be honest, just not a lot of people come to us on mepolizumab. That's usually a decision we kind of end up making together, because I think there's a little bit of discomfort if the person has what looks like EGPA from the asthma physician's perspective. I think there's less comfort starting them on mepolizumab before asking, do they need cyclo or Ritux, or what are they supposed to be on for vasculitis? So I wouldn't say I see a lot of people modified by mepolizumab before I see them. That would be something that we kind of talk about together. And Dr. Casson?
When you're assessing patients that have, at the onset of the disease, you're looking to stratify using that 5 factors. And you make the decision, in your experience of assessment, you haven't followed people maybe for as long as 20 years, but how many people evolve? And do you ever hear the question, or is it ever discussed, should I have been on medication to prevent this?
Yeah, so the question is about, initially when we see people, we try and stratify by 5 factor, but that's just an early snapshot in time. And do some of these people evolve to more aggressive disease? And should we be aggressive, or do we wonder if we should be aggressive up front, even with a low 5 factor score? I think the data behind the 5 factor score, and particularly the revised 5 factor score, is reasonably robust. There's over 1,000 patients in the revised version. So we do have some legitimate prognostic information that if you have a low 5 factor score, the likelihood that you die is low. That's not the same as saying you're not going to develop new symptoms. It's, less typical if you put them on good treatment. So let's say they are on steroid monotherapy or steroids and azathioprine. To develop new life-threatening symptoms absolutely happens, and Dr. Degan has seen more of these patients, certainly longer term than I have, so maybe she has some thoughts on it. But certainly people can evolve, and that absolutely happens. What I think about the most is people who had 5 factor score 0, mild disease, responded to prednisone monotherapy. Let's say they were ANCA negative. You did an ECG that was normal, but you didn't do an echo. You didn't do a cardiac MRI, and they actually had cardiac involvement. It was early on. Or you do an MRI, and they have a little bit of cardiac involvement. Does that mean they need cyclophosphamide? They were feeling fine. They had no clinical symptoms. You look for something that wasn't clinically evident. So I do worry about the converse, which it would be if we don't at least try to stratify, then we treat everyone with pretty potent immune suppression. So I think it's worthy of trying to differentiate. And if they flare or become more severe, then you have a different flavor for what their disease is. I think you can expect most people will have flares. That's pretty standard in the disease. It's a chronic relapsing remitting disorder. But for them to evolve to something really severe that they didn't present with, less typical, but absolutely like need to stay on the lookout for that. But that's a difficult, I think that's kind of, we need more longitudinal data to see who turns into what. Can you really stratify by the ANCA? Does that really tell you what their disease is going to be? That literature is kind of, it is shoddy.
Are there cytokines now being used to phenotype, if you will, or chemically type these different folks before treatment?
Yeah, so the question's about, do we use cytokine profiling to kind of define phenotypes or entities within EGPA? And not yet, but there are some, there are some cytokines and genetic, like there are some genome-wide association studies that show us like genetic variations in the disease, and that EGPA with overlap is distinct from other vasculopathies. It has very unusual genetic components to it. We didn't really get into that because honestly, it's kind of boring if you're not that into it. But cytokine profiles, we don't really dig into. Just the IL-5 is a major driver of the disease. And I'll just flip back to this guy here. So there are all sorts of cytokine profiles that have been derived from literature that are at least targets for therapy, but whether they're the driving force or kind of a consequence, that's not entirely clear. IL-5 was kind of an easy one because essentially eosinophils live because of IL-5. So if you turn off IL-5, you can actually just make all the eosinophils go away. So that one felt like if the eosinophils are the major problem of the disorder, we can probably reduce that. And mepolizumab does do that. It makes your eosinophils drop to pretty much zero.
I don't mean to monopolize, but it's very interesting. Are you now entering every one of your patients in a Canvas database?
So the question is, are we enrolling everyone in database? And Dr. Degan is doing more database work than I am. I'm not yet enrolling anyone. And I don't know if Canvas is currently taking EGPA cases. I think the like VCRC, I think they might be looking for EGPA cases.
Everything.
Oh, Canvas takes everything?
Yeah.
There you go.
And
Thanks, Natasha.
Would that be, Natasha, would that be your advice for everybody to enroll their patients in this database?
So the question is to you, Natasha, would you suggest that everyone be enrolled in the Canvas database?
I think the more data we have, especially about EGPA, because it's more of a rare disease, the better our understanding will be in a few years. So yes.
Okay. Any questions online? All right, I guess we'll leave it there. Well, thanks very much for listening. And yeah, no problem. Okay, bye folks.